Welcome to The Bigger Picture, a podcast series where scientists from King's College London School of Biomedical Engineering and Imaging Sciences and people with experience of cancer try to understand the bigger picture behind cancer diagnosis and treatment. What's it like to be a patient having a scan? What's it like being a scientist developing a new diagnostic test or cancer treatment? Together, we look at cancer diagnosis and treatment through the eyes of both scientists and patients in order to get clear on cancer and to look at some of the exciting research in this area. I'm your host, Maggie Cooper. Let me introduce myself. I'm a pharmacist and I've been working with radioactive drugs for more than 25 years now. However, my interest in cancer started much earlier than that. When I was 9 years old, my father died of cancer. I'm one of 4 children, and so my mum ended up having to look after all 4 of us on her own. She had to find a job when previously she'd been a mum at home, and things were quite challenging for us as a family. But it made me really determined to look into cancer treatment, and so that's how I've ended up working with radioactive drugs. It's a bit of an unusual field to be working in, but it's really exciting and there's lots of developments. In this podcast, I'm going to interview a series of patients and also some scientists from our lab. I'm hoping that the interaction between the patients and the scientists can help us forge new areas for research, maybe to think about things in a different way that we already do. Because being a scientist in the lab, sometimes we don't really get the bigger picture of what it's like being a patient, having cancer diagnosis and treatment. We hope that your experiences will help shape our research. In this episode, we're going to focus on breast cancer, and I'm going to talk to Rachel about her experience of being diagnosed with breast cancer. And then I'm going to speak to one of our scientists, Dr. Julia Blower. She's developing a new radioactive drug that can be used to look whether cancer has spread to the rest of the body. So first, let's hear from Rachel. I just wonder whether we can start maybe if you'd like to tell us a little bit about yourself.
Okay, well, my name's Rachel. I am 44 years old. So I'm going to try and forget these days. I'm married to Jonathan. I've got 2 children. Esther, who is 12, who started high school in September, and Nathaniel, who's 9.5, so he's in year 5. Very, very lively kids. Esther's into everything. Football, playing the piano, learning languages, and Nathaniel does nothing but Lego and Minecraft, really. And more.
Yeah, mine like Minecraft too. Well, we're on this podcast, we're here really to talk about cancer, and you have some experience of that. I just wondered whether you could go through if you can sort of take yourself back to when you first found out that you had cancer.
Right, okay. I think it was 2016. That sounds right. Yeah. Anyway, it must have been about the May or June. And I decided to go to the doctors because I found a bit of a lump in my right breast, and the doctor looked very doubtful and said she didn't think it was much, and she called another doctor in and they both said, oh no, that doesn't feel like anything, but we'll have to send you for a biopsy anyway. So I had a biopsy, which is one of the worst things that have ever happened. Probably biopsy was probably the worst bit of it, actually. And then I went back for the results, confident that nothing was wrong. And I was asked to go in and speak to the consultant, and I opened the door to him and he said, oh dear, are you on your own?
Oh, that's not a good start, yes.
No. So we then started a ridiculous farce where he said, can you get your husband here? So I said, yes, I think I can. I think he's in his office in Chester. So I rang him and he left work straight away. And I waited and waited. And eventually I phoned him and said, what are you doing? Where are you? And he was reading me all these signs you could see. And I said, where are you? He said, in the main corridor at Arrow Park. I said, no, I'm in Clatterbridge. So that wasn't a very good start. So we kept the doctor waiting for ages. And then, to be honest, I don't remember. There's an awful lot I don't remember. one thing I do remember is I can't watch Homes Under the Hammer anymore because they always had it on. They always had it on the TV in the waiting room. I always thought it was quite interesting till then, but now it just makes me think of the waiting room in Clatterbridge. So I can't watch that anymore. And pretty much straight away they said it's not showing. They'd done the biopsy. They said it's showing as sort of low to medium grade cells that are not invasive. So they said, we do recommend that you have the surgery, but relatively soon, but there's no rush. So as we were coming up towards the summer, I said, well, you know, they said, we've got to have the lymph node, you've got to have this done and that done, and the lymph node biopsy, and then we do the surgery, and we'll, you know, we talked about a reconstruction and all that sort of thing. And I said, if it's not urgent, can we make sure we can still take the children on holiday? Because he originally said, right, like the end of July. And that's going to be an awfully long time for the children to put up with being at home, having not had a holiday and not really understanding what's wrong with mum, because they were only 7 and 4 at the time, I think. And Nathaniel was just due to start school. So he said, no, there's no rush at all. You go and have your holiday, because the holiday was set for right at the beginning of the holidays, so it wasn't going to make much difference. So we arranged the holiday, went off camping in the Lake District for a fortnight, and halfway through that holiday, I ended up in hospital with something else.
Oh no!
I've never been in hospital in my life. So I ended up having other surgery, which resulted in the mastectomy being put off a fortnight.
So you say that the biopsy was kind of the worst bit, and that's interesting from my point of view, obviously, because we have got techniques which we're now using for diagnosis, and we want to try and use non-invasive techniques for diagnosis. So what did you find so sort of traumatic about the biopsy?
I just remember it kind of felt like being shot.
Oh.
It was just horrible. I can remember crying when it came out, after it, and nothing else struck me as that terrible for some reason. I don't really know why, because it can't have been as painful as other things that happened since. But that's what really stuck in my mind. You'll just feel a sharp needle. She said you'll just feel a prick from it, like a needle or something, a bit like an injection, and it didn't feel anything like an injection to me.
I think that the other problem with the biopsy is sometimes if you pick out the cells, you're not picking out necessarily a good mixture of the cells that are present in that.
Yes,
you might pick out cells that are fine.
That's an interesting point, because that is part of my story.
Oh, tell me.
Is that after I'd had the surgery, and they did a histology report? Is that what you call it? Where they analysed everything they'd removed. They said no, there were high grade cells. So that would have, while they still hadn't detected any invasive cells, but they said that once it had gone from high to medium, it's something I can't remember exactly. They said something like it actually doubled the chance of it becoming invasive within 5 years or something like that. They said. So because all along, like right from the beginning, he said, you know, we can't. He said, you know, I can't promise you will become ill from this little lump. He said it might never ever change, but my recommendation is that we remove it. And it turned out he was definitely right.
Yeah, sounds like
we made the right decision. It's quite likely I would have made me ill eventually. So yeah.
One of the things that you had there was a sentinel lymph node biopsy, and normally with that they inject a small amount of radioactive material. It's a small particle essentially, and that then flows from the breast area into the lymphatic system. And lymphatic system is the way that cancer, that particular type of cancer, can spread into the rest of your body. So they're looking to see if there's any cancer in those what they call the first lymph node, or the sentinel lymph node, to see whether that's whether it's spread. And the way that they can work, it's difficult to know which one is the sentinel lymph node. So these small particles, they get trapped in the first lymph node. So can you talk us through? Do you remember that particular procedure? You know, did you have a scan? Did they just put it in and then you went into surgery? How did it all work? Do you remember?
I think I went to. I think I had the injection. I think it was the day before.
Yeah, okay, that's
I just
reasonable.
had an injection and then I went for surgery. I
Yeah,
don't remember. I don't remember having a scan.
no, sometimes they scan, and sometimes
Right.
they don't. It's not crucial that
No.
they scan. It's more of a kind of almost like a confirmatory thing, and seeing,
Mm.
where, because sometimes it's difficult. Like if you have, for example, melanoma, can also spread in the same way, but it
Yeah.
can be quite difficult to work out where the sentinel lymph node is. Whereas with breast cancer, it tends to be in the axilla anyway, underneath the arm essentially. So
Yeah.
it's a little bit easier to work it out. And then once you're in the surgery, you wouldn't remember this, but they would have had a radioactive probe, and they would have been like using the probe to work out which one was a sentinel lymph node, and then they would have taken that out. So
Yeah.
did
They tell
did
me
it
that.
take out? Do you know how much they took out when they did that? Because this is one of the issues, that one of the things that we're working on is to try and minimize the amount that needs to be taken out, or even prevent anything having to be taken
I
out.
don't know. I've got a scar that's probably slightly about an inch long. Sure, I don't remember being told how much they were taking out. Actually, I don't remember thinking it was particularly awful, except that you have got this risk of I can't remember what it's called, that swelling up.
Yeah. Yes.
After having it done, I can't remember what you call it now.
It's a risk, and in the past it used to be much more of a risk. Before they had that sentinel lymph node test that you had, it was much more complicated. They take out all the lymph nodes, and obviously then the risk of having that sort of swelling was much greater. So that's quite a big progress in the last since I've been in the field, but I've been in the field quite a long time now. So it's good. But one of the things that we're working on in our department is like a tracer that will give an MRI image and a nuclear medicine image at the same time, and we hope that we would be able to tell whether that sentinel lymph node has got cancer in it or not,
right,
without having to do the surgery.
Yeah. I've not had any problems, but I've heard of people that have, end up, you could get infection in that arm or something. You can end up with all sorts of horrible swelling, and I've heard of people that happening to people. So it's quite a worry. It feels like a tiny operation at the time, but actually it can cause problems afterwards, can't it? So I think that'd be amazing if you can manage to do that.
Yes. So you did you have two separate surgeries? Did you have one surgery for that lymph node biopsy and another surgery for the actual mastectomy?
Yes. Yeah, the lymph node biopsy might have even been a month before. I can't really remember now. It was a while beforehand. Yeah. And then I had some reconstruction done while I was having at the same time as the surgery, which made it quite complicated. And then I had two more small operations afterwards.
I mean, they haven't given you any other treatment though, or have they? Have they put you on any medication? No, just.
I've been on tamoxifen.
Yes. Yeah.
I've just finished taking that.
Well, and then presumably they'll do some sort of check on you every so often. Will they give you a?
I have a mammogram every year. Yeah. Until they said I had to have that for. I can't remember. It was either it must have been 10 years. They said I would have an annual mammogram, and by that point I'd be in the standard system for having one every so often anyway.
Yes, I mean you're relatively young still.
Yeah, yeah, that's what everybody kept saying to me. And then I found out somebody my cousin knows, who was 2 years younger than me, got something very similar cancer a few months after me.
Yeah. What were your main sort of worries or concerns through this whole thing? Because I mean, I can't imagine what it's like being on your end of things. I don't know. I think if I was in your position, I think I would be sort of concerned for my children. Well, what happens if this spreads? What happens if it's really terrible and it all goes pear-shaped? I mean, were those concerns that were facing you at that time, or how did you feel?
Yeah. I mean, strangely, I find it easier to talk to you as someone I've never met than I did to tell my own family what was happening.
Yeah.
And yeah, it was a concern because it was they were so young, they sort of didn't really know mummy's going to have an operation, and that means they cut bits out of you. And that's about all they seem to understand. And they just thought it sounded horrible. And why are you letting them do that to you? One of them said to me. And Nathaniel was, I was stuck at home, not hardly able to move when Nathaniel had his first day at full-time school. My mum had my husband's work were very good, but my mum ended up coming and staying over for a couple of weeks so that she could take him to school every day, so it wasn't different people all the time. Yeah,
I mean, I think
that was hard. I never actually felt like I was ill
yeah.
as such, because I feel I feel really, really fortunate.
Yeah, so you were
But
lucky that well, you were and weren't lucky. You were lucky because you got it. It was diagnosed relatively early, and that was
yeah,
due to you being proactive and actually saying, "Hey, this lump isn't normally here," and going to your doctor. And I think that's probably a really important point, is to say, if you do have any
definitely.
concerns, go to the doctor. And even your doctors didn't think there was anything serious, but they still took the right course of action and
Yeah,
they sent you for the biopsy. Now, if you had waited, maybe you'd waited another year, then those high grade
very
cells
different.
may have become invasive, and that would have been another story altogether. So this
Yeah,
very early approach. So you say you're lucky, but actually, it was you. You're responsible for the fact that you're fit and healthy
yeah.
now, really. So
Yeah, as I say, it was major surgery, which involved some quite strong antibiotics afterwards, because it comes with, it's high risk of infection, isn't it, as well,
oh yeah.
from that point of view. But it was surgery and rest. There was nothing, I wasn't ill as such.
When I was at the Royal Marsden, I mean, that was an excellent hospital and they did things just really, really well. But you would occasionally see these people who had very, very swollen arms. And they were breast cancer patients who had had lymphodectomy, where they basically had the whole of their lymph nodes removed because they had got cancer in them. And that still needs to be done. There's not much you can do. If it's spread to the lymph nodes, then that's the treatment that you normally do, is to remove all the lymph nodes. But in patients who you don't know whether it's spread or not, then you wouldn't want to do that. I think in the past they did do it anyway, almost like it was a preventative thing. But then it's not actually that long ago, because it's within my memory, is when they started to do the sentinel lymph node studies. And in that, you had like a small radioactive injection, put it in, and then you'd use this probe in the theatre to see where the radioactivity is spread to, because it would get trapped in the first node that it reached, in the same way as the cancer cells would go to that first node and sort of get stuck there, or certainly reside there for some time anyway. So you could then find out which was the sentinel lymph node, and then you could remove that, and you could then analyze that and see had it got cancer in it. And if that node hadn't got cancer in it, or sometimes it's more than one of them, but those nodes hadn't got cancer in them, then you could be pretty sure the cancer hadn't spread and no further surgery was required. But if it had spread, then you could remove the rest of the lymph nodes. But even some of those patients who have that sort of more minor surgery, they still can encounter problems with the lymphedema. And so if we can do something to prevent them having to have that surgery, then we could really help patients in some way. So that takes us on to the work that we're doing in our labs in the biomedical engineering and imaging sciences at King's College London, and the work that you're doing, Julia. So maybe first of all, you could introduce yourself, tell us maybe a little bit about you, what's your background and how come you ended up working with radioactivity?
So my background, I'm a trained chemist. My lectures, when I was doing my chemistry degree, I was always very interested in the sort of biological application of chemistry. And so when I finished my my chemistry degree, I looked into what I could do with that, and came across this sort of area of nuclear imaging, and using my chemistry skills to attach radioactivity to these biological molecules to then use them in patients later on.
So you've had to sort of gem up on the biology side of things in order to do this role. You come with a strong chemistry background, but the understanding the biology of say cancer, or understanding how these molecules are treated in the body, or how they move around in the body is kind of a new area from what you did as an undergraduate.
Yeah, absolutely. So this area particularly is very multidisciplinary. So it involves chemists, biologists, physicists, mathematicians, clinicians, all sorts of scientists come together to solve problems surrounding disease. And chemistry is just a small part, and I wouldn't call myself a chemist anymore. I know bits about all of these things now.
Yeah, I mean, I think that's one of the strengths of the department, is that we have people with lots of different coming from lots of different backgrounds, and you can learn stuff of other people, and that really benefits the research that we're doing within the department. Let's have a look at this particular study, that one of the studies that you're working on, which is related to sentinel lymph node imaging. I just wonder, can you maybe explain a little bit about that project to us?
Yes. So as you were explaining earlier, one of the disadvantages of doing these lymph node biopsies is that some patients can have long-term side effects, as you described. And what we're trying to do is find a method of detecting which lymph nodes are diseased, but non-invasively, so without having to remove them. If they are diseased, then of course we will then remove them. But if we can leave them in place, if they're healthy, then this will help patients prevent side effects later down the line. So what we have is a type of particle. So these are SPIO. So this is super paramagnetic iron oxide nanoparticles, and these can be detected by a imaging modality called MRI. And when you inject these particles into the body, they have a particular feature, which means they are taken up by macrophages. So these are white blood cells which are circulating in your body, but there are particularly high concentrations of white blood cells located in your lymph nodes. So your lymph nodes are part of the system that sort of helps remove waste products from the body. So the white blood cells take up these iron oxide particles, and so you get this very high concentration in lymph nodes of healthy lymph nodes. And these show up on an MRI scan, and this will tell us that the lymph node is healthy. Now, when we have a cancerous lymph node, so if you imagine yourself inside a lymph node and you look around, all you'll be able to see is cancer cells. There will be a much lower concentration of white blood cells around because there's just no room for them. So you'll get a much lower accumulation of these iron oxide particles. And when you take an MRI scan, this will show a different signal. And so we can use this technique to tell whether a lymph node is diseased or not. So whether it's healthy. And if it's healthy, we can leave it where it is. And if it's cancerous, we can go and take it out. And that's the essence of our research.
So that's quite cool. So the lymph nodes that have got that haven't got any cancer in, they'll show up a nice little bright image on their MRI scan. And if there's some cancer in, you might get maybe like half, you might be able to see half of it. It depends how much cancer there is in there. If it's full of cancer cells, there's no room for the macrophages. And in fact, I think the macrophages can sometimes take up the cancer cells. So they're not then able to take up the nanoparticles anyway. So you kind of get a dulled signal or no signal at all. That's pretty cool. So now this imaging is going to require both. Let's see. You didn't mention radioactivity.
No,
where does radioactivity come in?
So So the MRI technique is very good if you want to sort of zoom in on a particular area. So the MRI technique specifically, if we look at a very specific area, so we know where the lymph nodes are, we can look at them and then say whether a lymph node is healthy or not. That's great. But what we actually want to do for a patient who's had cancer, we want to look at the whole body. And a much better technique for that is using PET. So this is positron emission tomography, and this is using radioactivity sort of attached to a molecule. So in this case, we've attached radioactivity to our iron oxide nanoparticles. And when we inject that particle into the body, we get this nice signal, and we can follow exactly where these nanoparticles are going. And on the whole body level, we can see where these nanoparticles go. So once we've then seen where these nanoparticles go or don't go, we can then zoom in on that area and then look at the health, the sort of health status of the lymph node.
Yeah, I mean, that's very important in certain types of cancer. So, for example, in breast cancer, the lymphatic system basically drains into the axilla, which is the bit under your armpit, essentially. And so that's not so difficult to find the sentinel lymph node in those cases. But maybe a patient's got melanoma, then that's much more difficult to locate where this sentinel lymph node is. And that's where our technique may really be very important. So would the patient then have to have a scan using a camera that can do both PET and MRI, or is it two separate scans?
So we have the technology to combine these two. A very creative name, the PET MRI scanner, so you can do both at once. But you can also do it separately. Obviously, the advantage of having it combined is that you have one scan. The patient only has to, undergo that one procedure. And we have that technology now, and hopefully these will be appearing more and more in the clinic and can help diagnose more and more people.
Yes, I think sometimes people think that it's, I think maybe people in the research side of things, not the patient side of things, often think it's competition between different scanning methods. Is MRI better than PET? You often see in the science literature something like that. So this imaging was better than that imaging. But in fact, when you combine these two different techniques together, it's very, very powerful, and it gives you a much better diagnosis than either technique alone. So it's a really, really exciting development, and it's something that has really been pioneered within our own department by Professor Paul Marsden, trying to essentially making their own MRI PET scanner. I remember going down to the PET center and seeing it in parts down there, the different bits of the scanner that they were making. So it's really, really exciting to see that actually coming into clinical use now. This is a great development. So let's go back to our project with iron oxide particles. So what sort of steps did you have to take in the development of these iron oxide, radiolabeled iron oxide particles?
So I think the function of the iron oxide particles is quite well established in MRI terms. But what was new is putting our radioactive atom onto the iron oxide. So first of all, we have to develop a method to attach our radioactivity to the iron oxide, and then we have to check that radioactivity stays on the iron oxide for the whole entire procedure. So that we call that our sort of the stability of the compound. So we have to measure that, and we also have to check the function of these iron oxide particles. So do they behave as we think they do? Are they going to be taken up by macrophages? What we don't want is for them to be taken up by cancer cells as well. Otherwise, we'll have the same image, whether it's a healthy lymph node or a cancerous lymph node. So we'll start in cells to check, are they taken up by white blood cells? Are they not taken up by cancer cells? And when we understand all that, we can move up and go into sort of preclinical models. So this is sort of small animals, and check on a sort of whole body level, and see exactly where these particles go in the body. Do they go to the lymph nodes, for example? And once all these things are in place, we can test to a certain extent, levels of toxicity. Once we've answered those questions and we're happy, we can then consider translating that into patients. And then that's becomes someone else's job. My job is up to the preclinical stage.
Yes, I mean, it's interesting, like how many little safety checks that we have to do. It seems like it's something sometimes quite straightforward, but it really takes a lot of time and a lot of dedication to get something like this to the stage where it can actually be used in patients, even in a clinical trial. We've talked about clinical trials. People have talked about clinical trials for the vaccine for COVID, for example, and how much testing is required. But the amount of testing that has to go on before you even get to that stage into the patient is quite interesting. And checking that things that the radioactivity doesn't fall off, as you say, or that it isn't, these particles aren't taken up into the wrong sort of cells. It's a lot of work that's gone into in any of these types of studies to get something into a patient. But it's quite exciting, isn't it? Really, I mean, it would be very good if we can actually do this in patients and really if you can save them a day in the operating theatre or a morning in the operating theatre, it'll really be a massive thing. But in the original the clinical trials that we will need to do, we'll have to use this technique and see what happens, and then the patients will have to carry on with a normal course of treatment, and then we'll be able to compare the results from our method and from the sort of standard method in order to work out whether our method works, and hopefully it will. And if that's achieved, then we'll be able to recommend this as a method for checking whether the patient's cancer has spread through the rest of the body. So yeah, it's good stuff. Thank you.
Thank you.
Thanks to Dr. Julia Blower there for giving us insight into some of the developments that are going on in our labs. And also thanks very much to Rachel for sharing her experience. Now, I thought it was really interesting that she talked about the biopsy being quite difficult for her. Certainly that isn't the case for everybody. I know other people who have gone through the same experience and had no trouble with that at all. But the main thing, though, that really struck me about the interview that I had with Rachel was that really it was her being quite proactive in picking up that there was a problem. And, if you do have any new lump in your breast that isn't normally there, is there anything that you're worried about, maybe the change of the shape or the size of the breast, especially if there's some sort of discharge from the nipples or swelling, a lump under the armpits, anything odd like that. Sometimes people get dimpling of the skin or a rash around the nipple. Any change in the appearance, particularly of the nipple, that is a indicator that there may be a problem. Now, it might be just a cyst, it might be nothing, but it's worth going to the GP and getting that looked into. Like with Rachel, she thought it was nothing, and it was good that they caught it when they did. Otherwise, if she had left it, it may well have been a much more serious problem. So this early diagnosis is so very important. I hope that you enjoyed this episode. Each month we'll be having a new episode where we'll be talking to scientists from our labs about the research that they're doing, and also talking to patients about their experience of being diagnosed or treated for cancer, or some aspect of their cancer, which I think you'll find interesting. So if you want to give us some feedback, if you enjoyed the episode, you want to tell us more, or you want to maybe be involved or even be interviewed, then you can find us on Twitter at BigPicPod, or at King's Imaging is our departmental Twitter handle. Or you can write to me directly at margaret.cooper@kcl.ac.uk. If you want to make sure that you don't miss the next episode, then please subscribe on your podcast provider's platform or app, and then you won't miss an episode. But until next time, thank you for listening, and bye for now.